Hello, this is Dr. Drew Moffitt, and this is another installment of our Facebook Live series. The title of today's presentation is the ERA test. What is it, who should have it, and when? There's been quite a buzz out there about a new test called the Endometrial Receptivity Analysis, or the ERA test. So I'd like to spend a little bit of time talking about what the test is, what we know about it, and how it might be used. One of the issues is it's a very new test, and it hasn't been completely definitively shown exactly what role it should play in the whole infertility process. So what the endometrial receptivity analysis is an attempt to decide or define better what is the window of receptivity. So back in the 80s, when we were trying to figure out when to put embryos back, there was a discussion about when the window of implantation was. What we mean by window of implantation is that the lining of the uterus isn't always receptive to an embryo implanting in it. And so if an embryo is put back too early, the window might not yet be open and it would not implant. If the embryo is put back too late, the window of implantation might have closed. We began investigating this when donor egg first started. When we're using donor egg, we would be taking an egg, creating an embryo from a person who is different than who we were going to put the embryo back in, the recipient. And so we had to spend time figuring out how long should we prepare the uterus of the person who's going to have the embryos placed in them, so that we are putting the embryo back at the correct time in the window of implantation. And from those studies, it was sort of thought that the window of implantation was about 2 days. And so because of that, we knew we had to kind of do it at the right time, but we thought the right time was fairly forgiving as far as that is concerned. There had also been studies where we would do endometrial biopsies, and we would try to decide when the window of implantation was, or what was a appropriate time to put an embryo back, and deciding on things like luteal phase defect and was the lining development not accurate. Those studies, those tests were not very accurate at all, and so there have been lots of different tests that have come out over the years to try and better define what is happening in the lining that makes it receptive and when to do it. And there were tests looking at just simply looking at the lining of the uterus under a microscope. There was then look at, there we go, sorry about that. We were then, there were tests where we would look under an electron microscope and look for things like pentapods. And then there began to be studies looking at the actual molecules that were expressed. Then with the onset of advanced genetics, we were able to look at many molecules that are being expressed at a given time. And when they would look at markers of protein production, they would find that at different times there were many proteins being expressed at different times in the lining. And so then there were tests to try and decide, well, what types of markers were actually suggestive of implantation. Anyway, long story short, because of that work, a group in Spain developed something called the endometrial receptivity assay. And they felt they were able to define a very narrow window, a much more narrow window of implantation. And that window might be as short as 12 hours. And they were then believed that they could pinpoint the time that would be optimal to put an embryo back. And that time was based on the amount of progesterone exposure. We believe that the amount of estrogen exposure to the lining of the uterus is fairly forgiving, and you can have a fairly wide variation in the amount of estrogen exposure, but the amount of progesterone exposure was felt to be fairly narrow. And in their studies, it seemed to be maybe as narrow as maybe 12 hours. So what they set out to do is to look at people, and at the time that we thought we would put embryos back, did their tests show that it was too early to put an embryo back, if it was the right time to put an embryo back, or if it was too late to put an embryo back. And they called those things pre-receptive if it was too early, receptive if it was the right time, and then post-receptive if it was too late. And they published papers just looking at the basic science of that. And based on their studies, for example, in one of the pieces of literature they hand out, they show that they've done this test in over 24,500 patients, and they found that the majority, 60% of the time, the patients had a receptive endometrium, but 35% of the time it was non-receptive. And when they were looking at the non-receptive category, 87% of the time it was felt to be pre-receptive, and 12% of the time it was felt to be post-receptive. And so that was a lot of patients, and that was sort of their data. Then there began to be studies looking at doing this test in people who have had multiple implantation failures. For example, they had what we call recurrent implantation failure. So these are patients who had done many, many IVF cycles and had failed all of them. Nothing had implanted, and they were trying to figure out, well, what can we do to figure out what's wrong and maybe fix it. So there were preliminary studies looking at people who had recurrent implantation failure and if this could help. And for example, there was a study published back in 2014, I believe. Just looking at the paper here. This was in 2013, looking at recurrent implantation failure. And it was a very small study, and in the end they had only looked at 8 patients who they actually did the test on, found it was abnormal, made a correction, repeated it, found that it was normal, and then went ahead and put embryos back. And there were 8 patients, but in that group and people who had multiple failure, they were able to get a 50% pregnancy rate. So obviously a very small study, but very encouraging. Then there was another study that was published as an abstract, meaning it was presented at a scientific meeting, but I hadn't been able to find the actual full publication yet. And this was presented in October 2014. And this was looking at, well, what is your pregnancy rate if you put back an embryo into a person who's had a non-receptive test? And what is your pregnancy rate if you put an embryo back in somebody who's had a receptive test? And this was a larger study. They had 52 people who had transfers one or more times into a non-receptive uterus, and then they had people who had transfers into a receptive uterus. And when you looked at the total number of embryo transfers into people who had a non-receptive uterus, and there were 100 transfers, no one had an ongoing pregnancy. Some of them got pregnant, but then they lost the pregnancy. Compared to those who had a receptive, 103 out of 140, or 74%, had an ongoing pregnancy rate. So that was very impressive, meaning that if you put an embryo into a non-receptive uterus, or non-receptive based on this test, the pregnancy rate was really not very good. The next test, or the next study that came out, was looking at this in a more real-world application. And this was a publication that came out in 2016. And basically it was looking at, okay, let's take people who have the test and the test comes back say, hey, you did it too early, you should adjust the time of progesterone to a little bit more, or people who had a test which showed that they had been on it too long and say, hey, you should do the implantation a little bit sooner. So that was the design of the test. So it was a little bit more real world, what you'd actually do. And this was done in people who were not people who had recurrent implantation failure, but they are just people who were starting out and had the tests done. And so they had three groups. One group that was having a fresh embryo transfer, kind of the way it traditionally had been done. Then a group who had a frozen embryo transfer, but had no testing done. And then a group that had the ERA test done and an abnormality was found, and then they corrected the abnormality and transferred the embryo. So that is sort of more real world. And in that study, it was fairly a reasonably sized study, though at the end of the day the numbers were fairly small. And to cut to the chase, they had 60 people who had transfers and were just fresh transfers the normal way. And in that group, 26 out of 60 had an ongoing pregnancy. So that was a 43% pregnancy rate. Then the group that had a frozen embryo transfer but had nothing particularly tested, they had an ongoing pregnancy rate. There were 33 out of 74 got pregnant and had an ongoing pregnancy, and that's a 44.6% pregnancy rate. And then the group that had the testing done and then had it put back, only when the test showed that it was good, they had a pregnancy rate of 27 out of 49, which is a 55% pregnancy rate. So in this real world study, essentially you could say that doing the test would move you, if you found an abnormality, would move you from a 44% pregnancy rate to a 55% pregnancy rate. So better. Now that was not a statistically significant difference because the numbers were so small, so that's important to remember. A larger study might end up showing that this is not statistically significant. In the flyer that they hand out, they reference a study that was published in 2016 also, and this was at a different meeting, and there they showed pregnancy rates of 55% more or less in the fresh transfer, 55% in the frozen transfer, and then more like 85% in the people who had the corrected test. Though in this particular document I don't have the number of patients in that cycle. So the bottom line is this is very interesting, very promising information. It certainly is impressive that when they put back embryos in somebody who had a non-receptive test, nobody had an ongoing pregnancy, and I think that's the most impressive part about the test. There is a large large randomized prospective trial that is being started at a group called Shady Grove, and hopefully that will give us more information of in a real-world application when it's done in a large setting. So right now we have to decide, well, how do we best use this test? And I'll tell you kind of how we're deciding to do that test. If we have somebody who has had 2 embryo transfers and has not had a success, or they only have 1 embryo left, that would be somebody who we would certainly offer this testing to. Also, if somebody has had the transfer of a chromosomally normal embryo, meaning an embryo that was tested to be normal, and that embryo was put back in what seemed to be a normal uterus and they did not have a pregnancy, then we're offering this testing to them also. And then finally, obviously, if someone felt strongly about this test and doing it right at the outset, we would do that. That's sort of the ultimate question, is should this test or tests like it be part of our routine infertility workup at the very beginning, meaning a person comes in and before we embark on anything, certainly in any embryo transfer in an IVF setting, should they have this testing done? And I think that's what this large prospective trial is hoping to answer, is should this be part of the basic workup and put back that way. For now, we have to make the best decisions out of the limited information that we have and do the best that we have. So that concludes this discussion on that. Next week, we're going to talk about another test which is somewhat similar in idea. It's called a endometrial receptivity. It's called a receptiva diagnosis test. And the purpose of that test is to be able to diagnose without doing a surgery if somebody has endometriosis. It tests for a particular marker called BCL6, and that marker is suggestive of active endometriosis that would decrease the implantation ability of an embryo into that lining. So we'll be talking about that probably next week. Thank you for joining us, and if you do have any questions, you can always reach us at our phone number, which is 602-343-2767. That's 602-343-2767. Also, you can contact us online at arizonafertility.com, and there's a Contact Us button. You just click on that and we'll answer that. Also, we have something called Talk to a Doctor today, and if you'd like to talk about this or anything else directly with me, you just call that number and ask for that, and we'll give you a call that evening. All right, well, have a great evening, and thank you for joining us. Bye-bye.